There you go. Now it works.
That was probably it.
Good call. How are you?
Yeah, doing okay. Glad, nice to have that done.
Yes. So we just completed the space training on ARFID and
Mhm.
would love to hear your thoughts.
Yeah, I think it provides a really nice platform, for structured parenting support, right? In a way that's easy to follow and digest.
Yeah. I like that the structure of it didn't feel so overwhelming because we had done already like the
Mhm.
regular space training before. I think like it felt like a good like just like addition to that.
Yeah, yeah, it gives a very tangible uh, plan, to follow, and carry out. It would be nice when the book is out as well.
Yeah, I was thinking about that. Where was it? Like the picky eating
Picky,
something, something. I know.
breaking free,
There you go.
breaking free from picky eating. I think so. That will be a nice companion guide for parents.
Right. Although, I was surprised that they were calling it that, to be quite frank.
It's a marketing thing
Oh, is that what it is?
because if you have the book on the shelf, you have people are going to pick up picky eating because they'll be like, oh, my kid's a picky eater because that's what people think of. They think of, oh, picky. So it's very much a marketing rather than a clinical like advertisement. We probably wouldn't call it that clinically.
Yeah, I was thinking about that because I was like, we usually try to say that our fit is more than picky eating, but
Yeah. They want us I mean they want to sell the book.
which more power to them, I
That's
think
that's
great reason.
that's what that comes down to, I think. Because I
Yeah.
saw that too. Because even she said in the beginning, like, how in the literature the term like picky eating is kind of mixed in, and they don't have like a good um, uh, sort of operationalized definition
Mm-hmm.
of picky or restrictive eating, and different studies use different operalize, I can't say it, they
Operationalized?
operationalize the terms differently, I guess, which
Yeah.
is where they sort of have that figure that was like between 5 and 50% of these ages and stuff like that. So it doesn't maybe offer um the research doesn't really offer a really good like prevalence rate because I think it's not well defined, and even within the ARFID diagnosis, there's so much variability.
Yeah. And I mean,
Um,
I guess that's maybe one of the first signs of maybe my kid has ARFID if they're
right.
being picky about what they're eating. But I
Yeah.
guess the important piece is also to ask why they're being
Right.
picky about what they're eating.
Hmm.
And not all kids really like grow out of it, right? Like I think that's the other piece.
Right. Yeah. And once again, I think somebody brought this up, and I was thinking the same thing, like especially as it relates to like fear of vomiting and emetophobia. And so at what point is that really just OCD? I mean, if someone has an additional diagnosis of ARFID, maybe it lends, the information that there's maybe a medical consequence in some way. But it really is maybe just more so likely just OCD versus giving someone diagnoses of, well, they have OCD, they have emetophobia, they have ARFID, and it's really like, no, it's kind of just the same thing, right?
Yeah.
In some cases, maybe not all, but
Yeah. So I was doing a presentation with Katie and someone
Mhm.
asked like the difference between like ARFID treatment and OCD treatment.
Mhm.
And I was like, essentially it's gonna look very similar.
Mhm.
And then also like how do you know when ARFID ends and like OCD begins?
Yeah.
But I was thinking, I think for people like if they have more than one theme or
Mhm.
concern or something
Yeah.
like that, then I would be like, okay, maybe like that's more like OCD.
Mhm.
When it's just prim like only focused in food, I would start to kind of be like, okay, let's look at
Yeah.
this as like ARFID.
Yeah. Yeah, and I think the big thing for me is like I'm very much like the term doesn't really matter to me that much. Like the term is like I guess it's important for research, right? Because you have to have a term or a name on something, right? So that we can agree, once again, how to operationalize a term so that when we're doing research, we know what falls under that category. But in clinical practice, things are much more um, muddy. And like whether somebody wants to call it OCD or they want to call it ARFID, if we're looking at the presentation correctly, the behaviors, and how it's affecting the person, right? And we're looking at the core fears or the underlying mechanisms of what's driving the behavior, doing a really good functional analysis, then we sort of know how we're going to treat it.
Hmm. Yeah,
So,
sure. I was gonna ask you because
mm.
when um I did like the fact that they really were considering including a dietitian in the treatment of ARFID,
Oh yeah.
right? Because as in my mind, I'm like ARFID is an eating disorder, right?
Mhm.
So we do want to take a team approach to the
Yeah.
treatment of an eating disorder.
Yeah, I mean, I think in general, right? If something is affecting eating in a way that we would be concerned about somebody's medical status,
Hmm.
then we're always wanting to, include, a dietitian, a medical provider. I think there was a great point made in terms of, lots of people have, sort of they were asking about the distinction between like, well, when would you use an emetophobia label versus when would you use an ARFID label? And they were speaking about how, well, a lot of people with emetophobia, for them, it doesn't lead to any significant medical consequences. Maybe they are, choosing one food over another, and maybe there's a little bit of avoidance, but not to the extent where it's affecting them on a medical level or it's concerning on that side of things. They might be in a lot of mental distress.
Yeah.
But there might not be a medical concern because if there's one or two like trigger foods or something, they're just foods that that person can avoid, and like by and large, they're going to be fine because, you know, um, and I guess that's where I get sort of stuck on the labeling and stuff
Yeah.
like that. Like, the labeling gives us information, like it's a communication tool, but like those could be really underlying could be the same thing, right? Like it's just for one person, right? Their obsessional thoughts around that lead them to, restrict a lot of different types of food because they're feeling really scared, versus the other person, their obsessional thought process leads them to maybe avoid only a couple types of things and it doesn't cause a medical, consequence. So like underlying, are they just sort of the same root in those cases?
Right, right. And then maybe just to guide treatment, right? Like who are you going to bring into the mix? But
Right. Yeah. Yeah.
that, yeah.
Yeah. So I mean, I think that's yeah. I think people get caught too much in the labeling,
Yeah.
versus like just really good assessment, what's being impacted, and knowing who do we need to bring on the team, based on what's being impacted. Just like with many mental health disorders, right? We might not need a psychiatrist, because the person's doing really well with treatment strategies and that works well for them and they're not needing, pharmacological intervention. But for another person with what we would maybe call the same thing, psychiatry might be very important for that person. So sort of, letting the individual symptoms, behaviors, and underlying mechanisms sort of dictate how we structure treatment.
I know. I feel like just like as clinicians, we're just so pressured to like diagnose. And I don't know. At the end
I've
of the
moved
day,
away from it so much. I
yeah.
used to be under so much pressure to diagnose and to have a diagnosis. I mean, it's like a lot of times like people, and people get very caught up in, somebody had a GAD diagnosis versus, being labeled an OCD diagnosis. I mean, I treat both the same way. If someone comes in with
Mhm.
generalized anxiety, if someone comes in with OCD, I treat them. I would treat them, both with exposure. I would treat them both with working toward tolerating, uncertainty,
Yeah,
acceptance of difficult thoughts and feelings. Because I think that's a hang up too for a lot of people sometimes, right? Where does generalized anxiety, become, OCD?
see. Where does it stop? Where does that begin? Yeah.
Right. Yeah. Or is it all just OCD?
And it's like such a I don't know. The DSM is
Yeah.
like why is it a week for this
Mhm.
diagnosis? Like
Yeah.
if the symptoms going on for like a week versus 2 weeks.
Right.
Like, we didn't
Right.
where did we get that
Right.
from? Yeah.
Yeah. Yeah. Yeah. I think, yeah, I mean, that's why I've moved so far away from that. I think it's a lot more for like insurance purposes.
Poor,
Really, like that
yeah.
you need to be able to have a diagnosis and code something, but these things are very different than distinct medical disorders where you can actually point to and say, oh, there is that.
Mm-hmm.
That is right there, right? We're not so advanced where we can just sort of look at the brain and say, there's OCD.
Right.
We could look at like maybe comparative like fMRI studies and stuff like that and maybe see different parts of the brain lighting up. But you can't have someone walk into an office, get a scan and be like, aha, there's the OCD. So it's
It is.
very much a medicalization of the model when things are, trying to say, oh, it's this amount of time. And if it's, that's why people fall into that other specified or unspecified category, right? And that's the primary right diagnosis for eating disorders, right? I don't know what the
Mhm.
percentage is, but most people fall into the other specified or categories because they don't fit cleanly into this, um, uh, criteria, that has been developed and certainly has some biases in it.
Definitely. And I think for a lot of people for with ARFID, they probably fall into that
Mhm.
at first. Some people, I mean, ARFID is still a pretty like new diagnosis. It's,
Mhm.
still kind of people understanding it. And I
Yeah.
feel like people probably fall on that first before, you know, getting appropriate care, like people
Right.
understanding like what is actually going on for them.
Yeah, and ARPID makes a lot of sense to OCD clinicians, I think. I think it's not a far leap for an OCD clinician who doesn't know much about eating disorders to conceptualize treatment for ARFID. More so, the challenge is helping people to understand, working with a dietitian and a medical team, for example. Like that side is maybe the larger learning curve versus the treatment in some cases,
Mhm.
being, significantly or drastically different with what we're doing right now.
Yeah, and I think one thing that really stood out to me from the ARFID, Space for ARFID training that we just did is how to navigate, I think maybe like the biases of diet culture that can
Hmm.
show up maybe with parents.
Hmm.
I think that even though yes, we're working towards parents not accommodating,
Hmm.
right, and being able to encourage their kids to eat different foods. I think someone had the question of like, oh, well, what if they're eating too much candy?
Hmm.
And my thought was like, yeah, what if they are? Like, what are we gonna do? But I think it's so easy to fall into, well, make sure they're eating enough of the good foods, and that's not really the focus.
Yeah. Well, I think it goes back to messaging and what's being reinforced in the home. And I think that's maybe a little bit of a missing ingredient, from the approach is taking a careful consideration of the language around food in the home is probably a really important consideration in any case that has things to do with eating, thinking about,
Mm,
how the family thinks about food. And they did talk about how food is very varies from family to family. I like
yeah.
that, but I would
Mhm.
go a step further and I would talk about um, how food is talked about, within families, and actually doing a really nice assessment with the parents about their um, opinions towards food, which they kind of did with the parents. They talked about what does food kind of mean to you,
I like
right? So that was getting at
that.
that. So I
Hmm.
think a little more of that, a little more of how do you talk about food in the home? What would it mean to have that your child is maybe having a few fast food meals a week, right? And is it coming up within that family that like, oh, I really don't want him having that at all, right? And and
Right?
and and really thinking about what is that maybe reinforcing, and how could that impact things later on too, I think is also a question, like in terms of eating disorder shifting.
That's a good point. I think they touched on restrictive eating in general, right?
Mm,
But I think definitely like the messaging that kids are hearing in the homes is going
mm,
to drive how they themselves
yeah.
feel about food.
Mhm,
Am I allowed to have this food
mhm,
or
mhm,
not? Or is there a certain consequence from eating this food or not?
mhm,
I think that definitely sets the stage, for
mhm,
potential
mhm,
turn into,
mhm,
anorexia,
mhm.
bulimia.
Right. Yeah, we always have to
Yeah.
consider that, right? Because these
Mhm.
things flip around. Right. And I think if you are doing intervention on a parenting angle, especially if you're catching at a young age, what would the harm be in providing, psychoeducation about what might be more helpful ways to speak about food within the home, and what might be some ways that could cause problems later on down the road. It's a wonderful intervention point to be able to address that sooner rather than later.
Well, I think like including uh like an intuitive eating practice to
Hmm.
ARFID treatment,
Hmm.
even with the parents, just
Hmm.
overall, just very valuable because we're helping them understand, right, that their kid needs to like relearn hunger fullness cues.
Hmm.
And with that also comes food choices,
Hmm.
based on preference, but also, nutritional need. It's like such a
Yeah.
balance,
Yeah.
um, because sure, when you have RFID, you probably have certain preferences based on fear, right? And probably sticking to what feels like safe, and maybe you're not meeting all your nutritional, needs because of it. But the whole point of intuitive eating is that eventually your body's going to tell you, right? Like, oh,
Hmm.
you kind of need some more of like this stuff. And
Hmm.
I think it's also about, helping the parents also give up some of the control, right? And kind of let the kid kind of do their own process of finding out like, oh, what is my body kind of telling me that I need? Not maybe my anxiety, my fear, but yeah.
Yeah, and I think that's where it goes back to, looking at what types of behaviors and language around food are modeled, in the home, and that probably looks, maybe also different based on the parent, as well. So I think it would be an important portion to consider in both like assessment and treatment.
Yeah, but I like what they also talked a lot about managing stress, and what they call it like the I'm trying to remember stress testing, right?
Oh yeah. Hmm.
So how to do stress testing with space,
Right.
space and ARFID. And I don't remember if there was a lot of that in the first workshop that we did.
Um, there probably was. I don't remember specifically, but it's sort of anticipating, I think of it about anticipating the challenges, right? So you're going to change an accommodating behavior. What is your expectation of, the possible responses, right? Because then the challenge is, well, you try to change an accommodation, and the child freaks out, and uh then you sort of just go back to accommodate and say, well, that
Yeah.
doesn't work, right? So you've got to have a plan in place for those challenges that are certain to come up, and like, okay, well, what are we going to do? If there's a meltdown, or if they,
Mhm.
just refuse to eat, or like, and those things are naturally very nerve-wracking for parents. So having a tool or a skill or a plan, I think naturally can help the parents to feel more confident in being willing to reduce an accommodation.
And I think normalizing that for the parents, that it's
Yeah.
going to happen. You're going to stop accommodating your child. And I mean, there's going to be an extinction burst, right? I
Mhm.
think that that's usually what parents maybe, like you mentioned, it's they feel like, oh, well, something is going wrong if they're having a meltdown. But if we think about it from the place that the kid has always kind of like relied on this accommodation, the moment that it's not there, of course, it's going to feel a lot more scary.
Yeah. And I think that's where the supportive statements are so important, because what is the typical messaging during one of those situations, and how might a supportive statement make a difference, right? Expressing that validation and confidence, in their child's ability, right? That, like, I understand this is really scary, this is really hard, and I have confidence that you can do it. Like, that's probably a big shift for many people.
Yeah, and I think most parents feel like they have to reassure their kid for their kid to be
Mhm.
okay, right?
Yeah.
Like, oh, everything's gonna be fine, or you're good, or this isn't bad for you. But they don't realize that actually what helps is helping them become confident, right? Helping them feel like they're able to deal with these things. And I think that's such a big shift for parents to be like, oh, I can still help, but like in this other way. Like, I think to be able to tell a parent, okay, you're going to not reassure, but instead validate and encourage. Just
Right. Yeah.
simple equation shift.
And once again, it's about what's going to help my child, and not aid, the eating disorder, or the OCD, or the anxiety, whatever we're plugging into, what's going to actually help them progress, even though it might not feel like the comfortable thing in the moment.
Absolutely. Right.
Puppy.
Once you apparently. Well, anything else you want to mention from the space workshop today?
No, just that I think, once again, I think it's a really nice manualized, structured framework, that I think can be, really digestible for kind of both clinicians to apply, and for families to learn. I think the book is going to be a great asset, as well. I think there's some value in giving the parents a chance to sort of read the book and see if you're on board with doing this type of treatment together,
Yes.
versus like, no, I'm not going to be on board with doing that. I think, sometimes it's you want to see how much commitment, right, there is to applying the approach, because you want to be effective, and to be a good use of everybody's time. So
I love that. So I hope that we can begin to integrate some of the space for our FID. Although, I mean, I feel like we're doing that already in many ways.
in a non-manualized way, I think
Mhm.
we're using a lot of the active ingredients.
Yeah, I think so too. I'm trying to think if there's anything else that I was gonna like ask us to touch on. No, I think it was great. I mean, I liked the ideas of also doing some of these like games with the kids, with like
Mhm.
having them, play a game while you're trying a new food and
Yeah.
making it like really interesting. Um, I think that kids get more excited, right? When
Yeah.
it's not just like a daunting
Yeah.
experience.
Yeah, and I think that can make it more approachable for anybody.
Yeah.
Even for, adults and stuff like that, right? And if you think about, we're approaching a fear, it's a way to kind of push back on the fear a little bit too, like similar to what we would do with any type of OCD work, where we try to help, the individual, push back on OCD with a little bit of humor, a little bit of levity,
Mhm.
right? Like this big scary food that's so terrifying to me, is shaped like I don't know, fill in anything there, right? Is shaped like a dinosaur or something like that, right? So there's something inherently sort of amusing and kind of diffusing about that, right? This big scary food looks, I mean, and I think that goes back to like something that's been done for a long time, which is right, like, parents cutting sandwiches into shapes or dinosaur nuggets. Like, I mean, when we think about a lot of different foods, just the look of it can make something, more appealing or easier for somebody to try. So I think that can be a nice stepping stone in this kind of work, making something a little more amusing or fun or a little bit of a game.
I mean, I don't know about you, but I still get excited about chicken nuggets, like
Yeah.
like the dinosaur shaped ones. Why not?
Yeah. Yeah,
Why
it's fun. It's fun. But because and it creates a contrasting experience, right? Because let's say that that's a fear food and chicken was a fear food, and now you're having a little bit of fun with it, right? You're experiencing maybe still that anxiety, but a little bit of like a kind of like a laughter reaction and stuff like that. It's not then purely associated with just this negative feeling in the moment. So I think it can be a nice stepping stone.
Or do you remember those like potatoes that used to be like,
The smiley
right?
faces and stuff.
Yes,
I think they
exactly.
still have those.
We still have those.
Yeah,
Okay,
I think so. Somewhere.
that's awesome. See, like I get excited about eating those. Like, why not?
Yeah, sounds good, right?
Yeah, that's awesome. But I don't know about the example they did with like the gummy hot dog. I was like, that's weird.
Yeah, I mean, that's it. I don't know how easy it is to get those types of things, but it's just another kind of fun game. Like you could get the gummy or you could get the thing.
Mm-hmm.
Of course, what if the parent like always gets the gummy? I mean, if
Well,
there's a
that would
fear
suck.
around the food, just being around the food, then there's a lot of value there though as well. Like if it's like I don't like just having the food nearby and the smell of food or the sight of food, if there's those sensory elements of it, or if there's even a contamination element, right? Having that food in proximity, like all of those things could be, exposures for the child. So there's useful elements there.
Yeah, and there's definitely like a lot of, steps that can be broken down into like smaller steps for someone to face a feared food that
Right.
like seeing it, even seeing a picture of it, right? Or
Mhm.
having the box the food comes in first before
Mhm.
even having it near them, but smelling
Right.
it. Like
Yeah.
that experience could be very gradual.
Yeah, there's good ways to scaffold it and make it into a little bit more of a hierarchy and make it approachable, which is good.
Right, and people then don't have to feel so discouraged because if they just say, "Hey, here's your fear food, eat it,"
Hmm.
probably people are not going to be so enticed to do that.
Right. Right. Yeah. Yeah, it's cool.
That was the cool stuff. All right. Well, any other thoughts on our training today and next steps? Do we have to do like a quiz or anything for that?
Probably for the CEs, they'll probably email it.
Yeah, we do get C's for that.
Yeah.
Oh,
Yeah, so
that's
they
cool.
should email that.
Awesome. I'll keep an eye out for that.
Yeah.
We still have
Yeah.
a